I've got my usual fruit salad of logos of the places I work for, but in addition, in the corner, you'll see William Shakespeare, because the title of this talk is TB or not TB. That is the question. I am proudly South African. These are the kind of things that I'm proud of. I would have married him. And perhaps him as well. But there is something that I'm not particularly proud of, and that is South Africa's TB stats. I've highlighted the things of interest. The first thing is, although our population is relatively small, we have 940,000 cases of TB per 100,000 per year. It means if you count us up, 1 in 10 of us are going to get TB in our lifetimes. That's a lot. So we are the highest, but because our population is relatively small, we have a relatively small number of infections. The next thing is how many patients in our clinics are generally HIV infected, and the answer is 44%, which is the highest anywhere in the world. The epidemics are feeding upon each other. If we have a look, these are the kind of statistics we're getting in South Africa in general. Our TB notification rate, the Western Cape is by far the worst, and the reasons for that are beyond the purview of this talk. These are the kind of case notifications we're seeing. So if you look at 1995 to 2005, the year Francois and I joined the unit, CHRU, we were very young graduates, but you can see that it's increasing exponentially. We're seeing more and more extrapulmonary TB. We're not being that successful in keeping patients on treatment to complete it, and we're having a high relapse rate. This is what the outcomes look like. Lots of people are dying of TB. People die, as I say to the younger doctors, if you're not finding TB, you're missing it. I hope your MPS is paid up. Okay, here's an interesting thought. We see a burgeoning epidemic. Obviously, the treatment of TB is TB treatment. But is there a potential way that we could use to control TB through antiretroviral therapy? This is very impressive work done by the group down in Cape Town by Karen Middlecoop. And the answer, what they've done is that they've looked on a population base as to what happens to the incidence of TB. And let's have a look at its highest. It's 2,500 per 100,000. And that was in about 2003. So what has happened is that we see a decrease that seems to be in opposition to the number of patients that are going on antiretroviral therapy. So obviously at an individual level, you can improve TB chances, but also on a community level, you can decrease the number of cases that you get. It's quite interesting. And then if we have a look at this slide, again from the same group, that we have a look at the number of patients and the chances of them getting TB, if they're on antiretroviral therapy, I don't think anyone would be surprised that that rate goes down. But so does the rate of HIV-infected patients getting TB, because it's just, kind of lowering the amount of acid-fast bacilli there are around. Okay, what looks like a duck? What quacks like a duck? And what walks like a duck? I beg your pardon. And the answer is quite simply a duck. With apologies to the English team, but that was a duck. What I'm trying to talk about is most clinicians have a kind of a gut feel of when this is TB or not. And I think that when you're a junior doctor, you don't feel it as often. But as you get more and more experienced, if it looks like a duck, it probably is a duck. But this means that we're having inaccurate diagnoses of TB. And what does that mean? The first one is we don't really know what's happening. If we don't pick it up, our patients die. If we overdiagnose it and overtreat it, we are exposing our patients to potentially toxic medications. We can debate that one. And we just don't know how big the burden that we're dealing with. So we need to have a look at diagnostics. The first thing that I learned in medical school is you speak to your patients, you take a history. And there are a lot of debates as to what we actually ask our patients to exclude TB. And there are a couple of ideas from various people. And this is kind of the things that most of us ask. Are you coughing? Have you lost weight? People go, I don't know. And I say, well, have you tightened your belt buckle? Because that's a clue. Are you sweating at night? Have you noticed any funny lumps and bumps? And this should be done by everyone at every single visit. So you should be saying from the receptionist onwards, are you okay? Are you coughing? Are you losing weight? But there's no real, we can't say which one is the more sensitive answer to the question. So then we go with the old standard of microscopy. It is older than both Francois and I put together times 2. So I'll do the maths. It is, look, it's done very well. And I think that experienced microscopists have a very high specificity and sensitivity, but it is dependent on a particular individual. And there are 2 or 3 types of stains that can be done. But this doesn't seem really good enough, because we well know in the HIV-infected population there is something odd. And what is odd is that they are often acid-fast bacilli negative. And it's inversely proportional to the degree of immunosuppression. Someone who's profoundly immunosuppressed, you're less likely to find the acid-fast bacilli. You look at a chest x-ray, but I think most of us in the audience have seen a slap-bang normal chest x-ray. And we think it might be TB, and it has been TB. We put the patient on a course of broad-spectrum antibiotics. It usually happens again by someone else, until eventually someone tumbles to the diagnosis that this might well be TB. Although I'm an academic and I will never excuse the bad practice of medicine, you're looking face-to-face with a patient who you think probably has TB, chest x-ray is a bit offish, they've got a CD4 count of 23, there is no time to wait for a culture. Even on the most sensitive measure, let me tell you, by the time you get it back, the death certificate's ink has dried. So how long does it actually take to make the diagnosis? This is work done by Graham Mankies on a group of 104 patients in which the diagnosis of TB was confirmed. Just short of 90% of these patients were in fact HIV infected. So it's looking at the proportion. So when someone starts with symptoms, how long does it take them to be diagnosed? And where do they go? Most people somewhere along the line will end up at a public sector clinic. You'll notice that this adds up to more than 104, and the reason for that is that patients visit more than one healthcare professional. Quite a few people go to their GP, so they start coughing, and you do what GPs do, you listen to the temperature. You listen to their chest, you take their temperature, and you give them a dose of whatever takes your fancy, augmentin, amoxicillin, whatever it is, and then they keep presenting. So lots of people end up with the GPs. Some people go to health practitioners that are not regulated by the same bodies as we are. And some people present directly to the hospital. And then what happens? As we all know, you can see the distribution in this group of patients is similar to what we see at the average antiretroviral clinic, more women than men. And surprise, surprise, the number of days it takes a man to get to the doctor is longer than that which it takes a woman to get to the doctor, and that is statistically significant. Okay, then once they've actually presented themselves at the healthcare provider's door and said these are the symptoms, how long does it take from then for the diagnosis to be proven? General practitioners are actually the best at this. They get the diagnosis made within just about 11 days. And tertiary care hospitals are the worst. They take up to 30 days. In defense of tertiary care, the people who walk into hospitals are usually sicker, and it is more difficult to find the diagnosis. They're not your average right upper lobe cavitation, spit in a bottle, you've got it kind of diagnosis. So that is, there are more complicated cases. But I'd like to note that the traditional healers are actually better than the hospitals in making a diagnosis. Okay, so who turns up at the clinics? It's found that people who are unemployed tend to get to the clinics later, and people who are employed tend to get there earlier. It kind of didn't make intuitive sense to me, because I would have thought if I had nothing better to do and I was coughing, I would go to the doctor. But obviously I was wrong about that. So in the worst case scenario, an unemployed male who went to hospital will take just over 3 months to be diagnosed with TB. And most, in this case, about 85 to 90% of these are HIV infected. So we just dial it back a bit. That means that this person has been coughing up acid-fast bacilli in some form for 90 days. No wonder we all have been exposed to TB. Okay, so we've decided that microscopy is not the best method, that even with microscopy, we've got up to a 3-month delay in the establishment of the diagnosis. So where to from here? Microscopy's disadvantage are the two that I've mentioned here. The first one is, I don't know whether these are live or dead bacilli, based on, well, they're all dead on the slide, but whether they were alive when the specimen was taken, or is this a contaminant, or is this fully treated TB with dead organisms? And the other thing is Mycobacteria tuberculosis are not the only mycobacteria that stain with an acid-fast stain. So you may be looking at a bunch of other things which may or may not be important. Avium intercellulare is not that important when you've got it from the sputum because it's not a sterile site. Of course, if you repeat that and keep finding it, it's a different matter. But a single Mycobacterium avium intercellulare, that one, it's not that significant if that's what you've coughed up on a single diagnosis. So let's think of something else that we can do. I mentioned it before. If we can't see it, can we grow it? Can we culture it? And there are certain disadvantages to this. Solid culture, which was the kind of what was done when I was a medical student and early doctor, took quite a long time. You could only declare it negative after 8 weeks. And as I say, when you're looking someone in the eye with a CD4 count below 50, they ain't got 8 weeks generally. It's relatively insensitive because you need 102 bacteria per mil. Seems like very few, but obviously not. So then midget or liquid culture was developed. It can come up positive a lot faster on far fewer organisms, but you can only declare it negative after 6 weeks. So you can say this patient doesn't have TB by this test after 6 weeks. So we're looking at something that seems to be pretty much like an oil tanker. We think it's there, but we can't turn around and find it. So what are we going to do next? My son is doing a BSc, and his major at the moment is molecular biology. And a lot of stuff was not invented when I was a medical student, and the little punk knows about it. So that's what we're going on to. We're looking at molecular testing. What do we have so far, and what are potential experimental things that are either in the market or need to be tested as a point of care? The first one that came on the market is produced by Hain Life Sciences, and can be used in acid-fast negative sputum. And what we can work out from that is if we don't see the germ under the microscope, if we can't see it, then can we find it on PCR? And the answer to that is yes. And we can distinguish between that and the other, we can speciate. We can say, yes, it is or it is not Mycobacterium tuberculosis. Then we can do an even more rapid test, which is called a GenoQuick, and I'll talk about that in a little while. What can we do with positives? I work in a hospital where we see MDR. And if you take it 90 days to finding the diagnosis of TB, you're going to take it to about another 4 months to make the diagnosis of MDR. And that's because the patient produces his second sputum after 2 months of treatment. If that's still positive, it gets extended by another month, then it's cultured, and then we find MDR. So that's a long time to be coughing up the germs. So what about we have a look at on a molecular testing, and the MDR-DR plus will find out whether you are resistant to INH and rifampicin, which will make you an MDR patient. And that requires, and we'll debate that in a little while. The newest kid on the block is MTB-DR-SL, which is looking at the second-line drugs. I'll talk, second-line drugs are drugs that are, second-line resistance is to a quinolone and an injectable, and that is XDR-TB. I'm sure you're all going, ooh, that's the scary one. But you know what happens at Sizwe Hospital is patients get admitted on the basis of their MDR diagnosis only. So they come into the hospital and we know they're resistant to INH and rifampicin. And the other drugs take quite a while to come up with the answer. Sometimes it's only done on the admission sputum. So it can be 6 to 8 weeks before we find out our patient is XDR. The XDR patients are sleeping next to the MDR patients, and 70% of our admissions are HIV infected. There is no doubt that there is nosocomial transmission of resistant organisms in a TB hospital. And if we could separate the wheat from the chaff right in the beginning and say you need to be in an XDR ward so that you don't infect anyone else, we would lessen the chances of nosocomial infection. What is being tried in our unit, or at Helen Joseph and I think at Witkoppen, is looking at a point-of-care gene expert. Because wouldn't you like it if a patient walks in and you say, I think this is probably a duck, but I'd like to tell you whether you're a duck or not before you leave my room, before you go home. Because if people don't return for their CD4 counts, I can tell you they're not returning for their sputum results. So what if we could tell them, listen, this test is positive. I'm going to notify you and treat you on the basis of this test that I've done in my rooms this morning. And this test these are being tried as point of care. It does not require a laboratory facility. It doesn't require the hoods and all the other things that are required because it's done in a closed container. Please don't press me for the details because I truly don't know them. So if we had a point of care diagnosis, it would be much more useful. And that can be done in a couple of hours. So you can speak to your patients, chat to them about all the things that are going on, and then tell them afterwards, you also have MDR, here are your tablets. So if 10% of us will get active TB in our lifetimes, almost all of us have latent TB in this room. My skin test ulcerates, and I have changed from when I was a student. The value of a skin test in adults is negligible, and I think its only real value is deciding or not whether we're going to give INH prophylaxis. I don't really see another point of it. In children, it's different. But even in children, what does a negative test mean? It means the child's never been exposed to TB or is anergic and is not mounting a response to the PPD. Who knows what the answer to all of that is? And a lot of the time, it's a difficult diagnosis to make. And unto that end, we have the test, the quantiferon has been developed, which is an antibody test to tell you whether or not you have been exposed to TB and have the organisms within you and therefore should be put onto some form of preventive therapy. The problem with this, of course, is in HIV negatives, it's a no-brainer. You take your INH for 6 months or so and move on with your life. But in HIV positives, we're not entirely sure what all of this means. And we've seen cases when the quantiferon has been screamingly high. And what does that mean? Active TB? I think that the jury's still out on that. The purple dots are what TB treatment is like now. And the purple and the red dots are what TB was like when I was a student. It's the same medicines, but it's just in fewer tablets. There have been no changes since I was a student of significance. INH was first discovered in 1912. And that is before I was born. So these medicines are not moving very fast. Nothing is really changing. There have been no new inventions in the recent time. And if you look at a lot of the drugs we use for MDR, the package insert is half a page. And that's because these drugs were never done in a randomized controlled clinical trial. They were never tested those ways. And the kind of the information we have on them is anecdotal and dependent on you and I to report to the MCC, which is not necessarily done very well. So there have been some new drugs which have been moderately promising. Moxifloxacin is going to be involved in. We're going to use a moxifloxacin regimen in our trial, in a trial at Helen Joseph, to see whether we can shorten the course of TB treatment. Rifapentine, it's a nice idea because it's got a much longer half-life and therefore can be given less frequently, but trials have not been outstanding. And then there's gatifloxacin, which is similar. It looks like a good idea, but data is still out. You know, in HIV trials, it's 48 weeks to an endpoint. In TB trials, it's far longer than that, to sputum negativity followed by no clinical relapse. Just to quickly pop over the terminology for MDR, monoresistance is a single drug and should probably be treated as an MDR. And I think, again, that the government hasn't fully made up its mind. Polyresistance is not both INH and rifampicin, but maybe one of the two plus any of the other lines. We have multi-drug, which is INH and rifampicin, with or without other drugs being resistant. And then XDR is resistance to INH, rifampicin, a fluoroquinolone, and an injectable second line. And anything else that comes along will make it an XDR. Okay, so we've talked about drug-sensitive TB. We've talked about drug-resistant TB. Well, we're embarking on the discussion of drug-resistant TB. They estimate in Africa that there are 66,000 cases and that there are 7,000 treated and notified. So that's the estimate of how many people, but we are not even scratching the surface. This is anecdotal, but looking at the prospective cohort that I have, about 20% of people have primary MDR. That means they got it, they didn't make it. They were not non-adherent to their treatment. There was a transfer of an MDR organism. And in fact, a case was described to me this morning of a 2-month-old child who had MDR on gastric washings, and the uncle was found to be positive for MDR. Okay, I'm not sure if this is going to project because it was something that I added at the last moment. But we have a patient that's been admitted who has defaulted twice on her MDR treatment. She was started on TB treatment and then found to be MDR, was admitted, defaulted again, and came again this last time because she was really sick. This is a slightly abnormal X-ray with the top cut off, but the bottom line is that she's got some left upper lobe involvement. It looks like old-fashioned TB. It's nothing really dramatic, and certainly if you culture an MDR from this, we accept that the diagnosis is correct. 2 months later, she came back, and if we have a look at that, that's more than slight. That is now definite. This is a fourth-year medical student diagnosis at this stage. But she again decided that this is not fun, and she discharged. She refused hospital treatment. In this country, you cannot restrain people because of the organisms. You cannot keep them without their will. You can only keep someone who says they're going to kill someone or themselves. But you have no legal recourse to keeping these patients in hospital. This is her X-ray on admission. She's got 2, I'm not sure if it projects. It projects fine. She's got 2 big holes in her lung. She's developed clubbing because there are probably some other organisms growing in there as well. Now she buys the concept because she's sick. She is indeed HIV infected, and I'm hoping she's going to stick to her treatment. This was a primary MDR of someone who did not adhere to their therapy. Okay, so we've dealt with that to a certain extent, but what are the new kids on the block? The first trial, which is a trial that's actually being conducted at Sizwe Hospital, was a quinolone-like substance called TMC-207. And it's used for not first-line, but second-line TB treatment for multi-drug-resistant TB. There's a very strange precedent set by this trial, and that is that the FDA usually requires 200 patients to have been exposed to the drug in a randomized controlled fashion. But because of the pressing need for new drugs for MDR treatment, the FDA will allow the registration of this drug now on an open label basis. But the first stage of the study was TMC-207, when the patients were randomized. It was a double-blinded study, and they were given the treatment, obviously in a double-blinded fashion. And they were given what they normally would be given and then added onto the TMC drug. And this is the results. This is the Kaplan-Meier curve of when the people cleared their sputum on culture. Please note there is a marked difference. And it becomes even marked when we look at the number of colony-forming units. This is a very powerful drug. But also scarily, one of our patients has resistance to this drug already. And not because it was exposed, but I think organisms just have inherent resistance. This is published data, so I'm not saying anything that's not out there. Okay, so as just to go through it again, this is a significant result with a very, very significant hazards ratio that nowhere near gets 1, crosses 1. So there's no doubt that this is a drug that's going to work. We want our patients to get better, and we want to stop them being infectious as soon as we possibly can. The study hasn't been unblinded yet, but I'm absolutely sure that we know which patients were given active drug by how quickly they gained weight, how much better they did, and how quickly they cleared their sputum. We haven't unblinded, but I bet you we're going to be right. But who's getting MDR? 70% of admissions to Sizwe are HIV infected. So what we need is a drug that will treat the severely immunocompromised and will interact some form of favorably with antiretroviral therapy, because if you don't find both, you are not going to be able to save your patients. So let's have a look at the other candidates. Okay, a drug OPC 67683. The exclusion criteria is CD4 count has to be more than 350. Rare as hen's teeth, let me tell you. Okay, then another drug that we're looking at is a similar drug, and it is also, they have to be on stable antiretroviral therapy, which is not that difficult to find in Sizwe because many of our patients, because of the long course of their illness, have tumbled to the HIV diagnosis and are in fact on antiretroviral therapy. Just another one that also has exclusions. Extrapulmonary TB, in fact, pulmonary TB is a WHO grade 3, so there we go. So now what about some really novel thoughts? In fact, I think it was William Clapham who talked about this to a certain extent. We've seen a patient who failed, and that's not uncommon. Why did she fail? She failed because she got admitted to a facility. She was separated from her family. She had to take fuffy medicines, including an injection in the bum, and believe me, intergluteal abscesses are not uncommon. All of those things put together. I don't know about this woman, but many of our patients are breadwinners. For me to be separated from my family for 6 weeks to 3 months is unthinkable. So what about if we treated these patients as outpatients? Is it possible? Can it be done? If you are sleeping next to someone and you've got MDR, if that person hasn't got MDR, they probably are never going to get it. So you've already exposed your close contacts. And I think the question not is, do they have MDR or not? The question is, if they have latent TB, what should we be using as prophylaxis? Now, I don't think you can run around giving children ciprofloxacin, but I think it is a study question that needs to be answered. What's odd about South Africa? Not Bafana, we rock. But what is odd? The bottom line is that things are spread around. We put our patients in hospital, as I've mentioned before, and then the patient goes home. The challenges that we face, patients, once they're discharged, they've got to come back to us. And we've got patients that have come as far as the Eastern Cape. The infection control is not adequate. Certainly it says where it's good, but it's not at all hospitals. And MDR patients do have the right to refuse admission. We've got a high burden of TB and HIV. Lots of patients. And in fact, in the Western Cape, patients are on the waiting list for admission to an MDR hospital, is all I can say to that. They continue to spread their multi-drug resistant organism, which is not a good thing to be doing. Of course, like everything, we need to select out the good candidates. We need to have someone who's who is in relatively good health as these things go. They need to be able to get to and from the MDR treatment site. They need to be living somewhere, some form of stable accommodation. I don't know if any of you guys work near Helen Joseph, but there's a guy there who lives in the drain. So I don't think that we qualify that as stable. And they should have a reason not to want to be hospitalized. And I think having children and a family to support is a good enough reason. Okay. So we've covered how you find it, what you find once you've dug around and find it, what do you do about it, what are the new options that we have. And now let's talk about how do we prevent TB. Is it possible to prevent TB? Should we be using INH? Should we be using antiretroviral therapy? Should we be using both? I think what I'm going to do is I'm going to present an argument as to what we should do, bearing in mind that there is latest research that was presented at CROI, and I'll come to that right at the end. Okay, who do we choose? If I'm asking you secretly why you don't use INH, I can tell you why I don't. And the answer is, I feel a difficulty in putting my hand on the Bible and saying this patient doesn't have TB. Everyone has had a kilo or two of weight loss. And, they did have a cough 3 weeks ago. And yes, they did sweat last night, even though it was hot. And to be absolutely sure on clinical grounds that someone doesn't have TB is enough to kind of put me off giving INH. And that is against all the other kind of cogent reasons, like D4T and INH, peripheral neuropathy, hepatotoxicity, which can be fatal. So you're not even counting all of those. There are lots of reasons why I think, if clinicians are being honest, why they're not doing it. Then the other things are to get your patients to adhere to it. How long do you do it for? When you stop, how long before you have to restart it? So I think that that's one of the reasons. However, it is a recommendation by the National Department of Health that we ought to be rolling out INH prophylaxis. So if in doubt, and I think these are clearly in doubt patients, look for TB. And if you think that they might TB but you can't prove it conclusively, wait a wee while and then test again. If the patient has put on weight in the absence of TB treatment or their cough has settled down, then they probably don't have TB, in which case you can use isoniazid. How do you do it? Okay, a standard dose of 300 milligrams a day. You give pyridoxine to hopefully protect their feet. You talk about adherence and tell them why it's necessary to stick to their treatment and the adverse events. And obviously you say if you start coughing up stuff, what you need to be doing. If you're losing weight, please come back to us so that we can then proceed to start you on TB treatment if necessary. Again, as someone walks in the door, we all say the same thing. Hello, darling. Are you coughing? Are you sweating at night? Are you losing weight? And then we be careful of our side effects, which I think I've covered, and then be sure that they are taking their medication. I do not think that you can use any other drug as a marker of potential adherence or non-adherence in patients. I think so long as we start saying you've got to wait to see whether someone can take a medicines before we give antiretroviral therapy, A, it's against the guidelines. We need to fast-track patients who are sick, but also I think it's a really unfair thing to be doing. If you're going to take your medicines, you're going to take your medicines. So, should we be giving and or isoniazid plus antiretroviral therapy, or what is the answer? We do know that the leading cause of HIV, the leading cause of death in HIV-infected patients, even on antiretroviral therapy, is TB. And that if we combine the two, we do get some form of efficacy. It is an improvement. As you proceed on antiretroviral therapy, your chances do decrease of developing TB. I think that was shown quite graphically by my slides from Karen Middlecoop. So yes, it does decrease, but if you are HIV infected, your risk is never the same as if you were HIV non-infected. You always have a slightly higher risk. Then the next question is it as effective as art? Yes, in HIV negatives, sure it is. If I wanted to practice medicine in the States, I would not be allowed to do so, presuming that I was HIV negative, unless I had taken IPT. So it does work. And then remember, your patients are sitting in a swarm of acid-fast bacilli when they come and sit in your clinic. Many clinics do not have adequate infection control. The rooms are separate from the windows, which are the best way of preventing nosocomial transmission. So you're giving someone INH to prophylax them against TB, and they're sitting next to a person with TB. I don't think that that's sufficient to prevent certainly reinfection. What about INH resistance? That's a thing that wakes us up at night and saying, if I'm giving this person a drug, are they going to end up under Francesca's care in Ceswell Hospital? Am I predisposing them to something that will give them a problem? Yes, INH resistant is a possibility. It's a very active drug, and if you have a low bacillary burden, it is enough. But if you are even on the beginning of subclinical TB, it probably is not enough, and you are likely to develop INH resistance. And INH rifampicin, those are the cornerstones of our treatment for TB. And if we lose them, we've got a big problem. So it can develop, and in cases, I haven't been able to download the slides from Croy yet, they randomize patients to getting IPT for a short period versus a long period. And in those, there's a placebo-controlled trial done in Botswana. In the patients who got it for only 6 months, very shortly after stopping it, their rate of TB increased, and the rate of MDR was higher, although not much above the background level of MDR. So who knows? But it is something that's the reason that we need to keep an eye on all of that. IPT, what is Francesca's advice? The National Department of Health suggests in strongest terms that we begin to roll out IPT. Should we be doing skin tests? I think in the skin test negative there is little value of doing it, but it is not in the national guidelines that we do skin tests, because skin tests are a pest. I don't want to have another skin test because I'll get a scar on my arm. They've got to be read within 3 days. What constitutes a positive and a negative? I mean, there are definitions of that, but we need to be careful. Start, watch out, and the literature is moving. As I've mentioned, 6 months, according to the Botswana study, is not enough. If you're going to give someone INH, you give it to them for a minimum of 36 months. And just based on the data, I think when you stop that, you're going to get back to square one, and the incidence is going to start to rise again. So, I started with a quote from Shakespeare. Now that we have the interaction between HIV and TB, let's say the following: cry havoc and let slip the dogs of war.